I'm Dr. Rick Greene, and it is a pleasure for me to host a series that is supported by our UVA Medical Alumni Association, which really honors our emeritus professors and our wonderful faculty here at UVA. It's an absolute pleasure today to be with Dr. Peyton Taylor, a colleague and longtime friend. So Peyton, welcome to this series.
Thank you very much. Glad to be here.
First of all, I want to congratulate you on the recent scholarship that was named in your honor.
Oh, thank you.
For research, for GYN fellows and residents. I know that you originally came from UAB, from medical school. You've been here on a variety of occasions over almost 40 years of being on the house staff, faculty, and whatever. Tell me a little about your interest in research, because obviously they're honoring you for some research interest. You're a wonderful clinician, but what about research? How has that played a role in what you've done?
Well, I got my start in medical school. I was in a combined degree program in medical school and worked with a wonderful person who was a mentor. I had an opportunity to drop out of medical school for a year and work on the PhD off and on. And then I came back my clinical years and found out my love was clinical medicine rather than research. But the grounding in research was a great opportunity that was afforded to me by a scholarship. And so in founding this scholarship, what we wanted to do was to give other future students and future residents an opportunity to take a little deeper dive into research in women's health. So it's a broad-based, cross-ground scholarship to afford people an opportunity to serve with a mentor in one of the many schools of the university.
Well, I know that you're loved by your fellows and residents, and that's obviously what generated this. You and I know each other through some of our cancer interests. How did you become interested in GYN oncology as a byproduct of gynecology?
Well, actually, I started out here in internal medicine and peds, an elective, and thought I was going to be an internist because I came from UAB with Tinsley Harrison as a mentor on attending on the ward. And my last year I met John Kirkland in general surgery and sort of did an about face, but I was already accepted as an intern in medicine and didn't know exactly what to do, and applied for one of the public health service positions at the NIH, and was then lucky enough to get into the surgery branch. So I approached Dr. Thornton. I said, Dr. Thornton, I'm in a big problem. I've got a position in surgery, but I'm an internist, and that's an awkward situation. And he said, well, I'm full, but I can sort of help you out. So he talked to Harry Muller and to Dr. Fitzhugh, Slaughter Fitzhugh. He said, well, you can rotate through general surgery and head and neck and GYN onc, and I'll call you an OBGYN resident if you take OB call 2 months. And so I did, and then I got to NIH and did the 2-year general surgical oncology fellowship, and decided that I liked to work with women and I liked cancer. And it also dovetailed with my research project in cell division, which I'd done as part of my graduate program. So it was a way to combine the research interest and the clinical appeal of cancer care. And I enjoyed working with women.
Over the years, in looking at your specialty, what are the things that stand out to you as sort of the highlights, the real benefits in the care of women with cancer and reproductive cancer? What are the highlights for you?
Well, I think the initial recognition that if you concentrated your efforts and specialized in gynecologic oncology, it wasn't a specialty when I started my residency program. And Dr. Thornton was president of the American Gynecological Association and proposed that GYN oncology become a specialty with a board, an examining board. And so I was fortunate enough to be a resident at that time, and I wanted to follow in his footsteps and take care of women with cancer. And I think it's made a tremendous difference, is to having a group of people, multidisciplinary, groups working and focus on women's cancer. And we sort of focused on reproductive tract cancers and not breast and reproductive tract cancers, although that was an appeal. You had to politically sort of restrict yourself.
As a general surgeon, I felt the politics
Yeah.
of GYN and oncologists in breast disease, of course.
Yeah, and it was a little bit difficult getting started because we started doing intestinal surgery as part of the large resections, and that was somewhat of a conflict with general surgery. But fortunately, Scott Jones came as chairman about that time, and he was very, very accommodating, and it worked out.
Well, you, like I, trained in the era of open traditional surgical approaches.
Yeah.
When minimal access came in, especially laparoscopic approaches in GYN and GYN-onc, how did you sort of transition, or what were your thoughts about that?
Well, actually, I didn't. I hired people who were trained in minimal access surgery. So I was the person who continued to do the open cases and had a lot of young people who were adept and trained to do minimal access surgery. So I never really made the switch. I just populated the program with people who did.
Let's think about your time here in Charlottesville. What I like to ask my interviewees is, what is it about Charlottesville that's kept you here over the years?
3 different trips. I don't know. Initially it was the appeal of the faculty, the small size of the faculty, and the relationships with other departments. We had a great working relationship with urology, general surgery, head and neck, and internal medicine, so that you could call on people to get help and to give you ideas. And I think our strongest relationships were things in areas that were potentially adversarial. Urology and GYN in some places were adversarial. General surgery and GYN in some places were very adversarial. And here it was not that. We had a very collegial relationship. Our room was next to, sandwiched between general surgery and urology. And so we could go in the scrub room in between, and everybody worked together.
So what have you been doing since you transitioned out of the world of GYN-onc?
Well, when I stopped operating, I was a little bit restless, trying to find something to do. And about 3 years before I retired, I started a program in telecolposcopy, which was providing colposcopic services, women with abnormal pap smears that were uninsured in Southwest Virginia. And I had gotten so tired of traveling back and forth to Southwest Virginia. During those 3 years, I thought there would be a better way. And so we ended up getting high-speed internet in Wise, Virginia, setting up a colposcopy service, trained nurse practitioners to do colposcopy, and I supervised them by video with a live camera feed. And that continued until September of this year. We first funded it with a tobacco indemnification grant because it's a smoking-associated cancer. And it's working well. It's now continued, and it's turned over to the Department of OBGYN to run as a service program. And so that was one thing, and I enjoyed doing that. There was a monthly clinic, and it was fun and innovative. The information management system was critical to making it work. And then about 2007, I started volunteering in East Africa, thinking that I would go there and do fistula surgery as something to do, keep me busy and contribute. And then I realized that cervical cancer was the leading cause of death in East Africa for women, and I said, well, maybe it's something else I could do, and cancer prevention rather than, I initially thought we'd do cancer surgery, but the cases were so advanced we needed early detection and cancer prevention program. And I got invited to join the faculty at Duke on Women's Global Health, and they have a consortium in East Africa, so there are 2 of us who rotate roughly every 3rd month for a couple of weeks at a rotation. And we run a research program and a clinical service program, teaching residents there and trying to improve the educational and experience of those residents and increase the infrastructure on site.
That is wonderful.
So
Has vaccination for HPV caught on in these countries?
the idea is caught on. The money for vaccination programs is not there yet. So Tanzania had, I think, vaccinated 250,000 young people out of a country of 50 million. It's hardly enough. And it will take a while. You need screening programs for women of today. The vaccination programs are for the women of tomorrow. So it needs to be a joint program. So we've got a good research program now looking at a tool to screen women with a vaginal camera that hooks into an iPhone, and we send it to reading stations. And one of the reading stations is here in Charlottesville, one is in Durham, one's in Lima, Peru, one's in Zambia, and one's in Nairobi, where we have retired faculty who look at the images and say, this person needs to come in to be seen by a doctor, this person's cervix is normal. And we're integrating that with HPV data that we're collecting through a collaboration with the University of Southern Denmark. So we built a little collaboration program.
Well, like so many of our faculty, you haven't retired. You've transitioned to something even more important, perhaps.
Well, not more important, but it's different.
It's been a pleasure to talk to Dr. Peyton Taylor today in this series for the University of Virginia Medical Alumni. Peyton, thank you so much.
Well,
Pleasure to be with you.
Thanks for inviting me. Yeah, great.